before I bring up Dr. Sullivan, I just thank you guys so much for these great talks. So in the beginning, we heard from Dr. Wheelis and Dr. Worrell that sort of set the stage of what we know and where we're at in LGS clinically. And then we just heard 4 excellent talks about some research that is going on, looking at devices, we didn't even get into the medications and ASMs that are being tested, but we did hear a little bit about that. And then now we're going to jump into Dr. Sullivan and Dr. Schrey, who are going to be talking about, Dr. Sullivan will be talking about clinical trials in LGS specifically, and then Dr. Schrey will be looking at the evolution of the EEG from infantile spasms to LGS. And all of these are meant to bring up questions that we hope to answer at the upcoming meeting of the minds and get you thinking about those, but really wanted to bring this information to you. So with that, I'm going to bring up Dr. Sullivan, and he'll bring it home with the last 2 talks, and then we'll bring up our discussion leaders. Thank you.
Thank you, Tracy. Can't wait to tell my wife I was on stage at the Johnny Cash bar. If they break out in the Folsom Prison Blues, I'm downstairs. We're going to all start singing along. So Tracy asked me to talk, about some of the outcomes in addition to seizure control. For all of us epileptologists, obviously in the audience, we treat seizures, but if your clinic's like mine, we spend the most of our time talking about all the other stuff beyond seizures. And while I'm not a clinical trialist, I've had the opportunity to participate in a number of clinical trials over the last 6 to 7 years, and it's occurred to me that this is such a precious moment that we have to be able to ask and potentially answer some questions, but we have to be careful to not ask too many questions, and the questions that we do ask hopefully are very high yield. So in the spirit of starting the conversation, I'm going to end with a calling for us all that we can maybe revisit when we convene again. So again, the focus of this is going to be on non-seizure outcomes, but these still are epilepsy trials, and like it or not, I think the primary outcome is almost always going to have to be seizures. But I think we've actually come a long way, specifically with LGS trials, just acknowledging some basic things, right? Not all seizures are countable, and even seizures that are countable, even all of us in the audience who are very well-meaning clinicians, focus on semiology, we call things different things just because we're different, right? And so this one definition of drop seizures, I think, has been fairly pervasive through a lot of the LGS trials, and I think it's been extremely valuable. And I'm not going to read through it, but hopefully we would all agree that there are many different types of seizures that could lead to a so-called drop. And I also think, full disclosure, independent seizure review, I'm a member of the Epilepsy Study Consortium, which a lot of, as are some others in the audience, and a lot of trials now are using the consortium to really vet these seizure types to make sure that we're calling an orange and an apple. And I think that has also gone a really, really long way to improving how cohesive, I guess, our outcomes are. So I'm going to use an example of the most recent medication that was approved for LGS, fenfluramine. I saw Kelly Knupp just left, but Kelly was the coordinating investigator of this trial. And just to show that there are also many different ways, as we know, to look at primary outcomes, right? We can look at median reduction in seizures, and we can see here in the treatment and maintenance phase that the higher dose of fenfluramine was statistically significant, superior in terms of reducing seizures versus placebo, but the medium dose was not. Keep that in mind as we go through a couple of other slides here. But then if we also look at the so-called responder rate, and we can see that this is, again, a different way of looking at the data, but the so-called 50% responder rate that in this trial, there was at least both the low dose and the higher dose was statistically significant over placebo. So it's one way to look at that. And then this is all great, right? But if the drug actually reduces seizures, but worsens sleep, worsens behavior, that's a bad outcome, right? And even if you take someone who's seizing 100 times a day and you add all that up, and now even add up the recovery time from those seizures, that still probably leaves greater than 90% of the day that they're not seizing. So what are they doing during that 90% of the day? They have to sleep, they have to eat, they have to listen to their mom, dad, caregiver. Maybe they have to get up and help get dressed. And I think we've heard it loud and clear from our patient families that these things, while seizure control is important, these things are equally, if not more important, and we need to start measuring whether or not these things can improve with our new medications. And so one way of doing that is just to ask a question, right? Like Brenda just said in the DBS, are you better? And so in this fenfluramine trial, When you ask that question, you can see here that there were higher percentage of patients that thought they were better, even though they may not have had that same 50% reduction in seizures. So what's driving this? And I think this is taken right from the LGS Foundation website. This is a large survey of caregivers of over 400 patients, and we can see that having seizures is still number one, but not by much, right? All these other things are so important, and I think we need to, as a community, come together to figure out how are we going to start asking some of the questions as to whether or not some of these things can improve. So how are we going to do that? I think we all agree that change is possible, but over what period of time? We have 12 to 14 weeks usually in these trials to see if things can change. So is that enough? Maybe if we ask the question in the right way, it is enough. And so that gets into how to measure it and how to ask that right question. And then why do we care? Yes, the FDA labeling and approval is important, but selfishly, I just want to know what I can look my patients in the eye and say, this may help or this has not been shown to help. And I think that our families really expect and deserve that. So again, taking it one step further, this is a very busy slide, and I realize you can't read a lot of it, but in that same trial, I applaud some of the sponsors now for including some of these measures, but I think now that we have some data, maybe it's time to take a step back and say, is this the right way we actually should be going? So in the fenfluramine trial of LGS, this behavioral rating inventory of executive function was included, and it was actually included primarily as a safety measure, right? We wanted to make sure that patients weren't getting worse. But lo and behold, as you went and look at the data later on, there was some movement in a positive direction that these patients are getting better. And hopefully we would all agree if you can read some of it here. I mean, these are the important things, right? Making transitions, maintain consistent mood, manage emotional stress, right? Our families want to be able to take their kid to the grocery store and be able to shop for 20 minutes and not have there be a meltdown. So I think these are things that can be assessed by these types of questionnaires, but again, maybe there's a better way. And so here were the results in the fenfluramine LGS trial. And so if we look at these, each individual, I'm dizzying up here. So we look at these different indices, and the reason why I asked you to hold in mind the difference in the low dose versus the high dose, while there was not a statistically significant difference between low dose and placebo in terms of overall seizure reduction, we can see here in these different submetrics of the brief, the low dose and the high dose were pretty similar, and all were superior to placebo. So then that, again, there may be many reasons for this, but does this argue that in this trial that maybe fenfluramine was having an impact independent of seizures on some of these subdomains of the brief? And then again, it's a busy slide to look at, but you can look at all of the other different subdomains of each of these indices to see that some of these things may drive a lot of the change and others may not. So while it was included as a safety measure, I think this gave me, at least, I can now sit down with families and say, yes, maybe we can get a 25% reduction in seizures, but also maybe we can hope that some of these other things actually would also improve. And so I think that's starting to at least get at this one line item here with regard to behavior changes, but we can hopefully spend some time in May going through many of these others. And so this is, in preparing for this, I looked to see, well, how can we include some of these outcomes and make FDA happy? And having gone to a couple of the Epilepsy Foundation research roundtables with Jackie French and things, I stumbled across this, not a very light read. I don't necessarily recommend, well, there's industry people here, you guys can read it, but this is not a light read for clinicians. But some draft guidance, right, for how to study some things in rare disease. And this is just poached right out of the document. Basically, we need a clear statement, the trial objectives, statement and rationale, sample size, and the summary of the methods, but a design that permits a valid comparison with a control that may be concurrent, limited, or in special circumstances, historical. So I started thinking again back about that clinical global impression of change, just asking a question, are you better? And can we do something like that, but maybe, parse it out a little bit more specifically? And this is where there are a couple of other disease states where there's publications where groups have gotten together and developed their own syndrome or disease-specific scales. where they actually use them both in clinical practice, but they're also promoting that these actually be used in research. And I thought this was one of the ones. There was the one done in Rett syndrome as well, but I thought the Angelman syndrome one was done really well. And this actually is a really nice paper. And basically what they did is they went through this sort of hierarchy in terms of developing this. So they determined what were the clinically meaningful symptom domains. So we basically have that graph already from the LGS Foundation website based on caregivers to understand what things do our parents and our families want to look at. And then they assembled expert clinicians. So pull up a chair, right? We can just sit around and start talking about this, right? About how do these different symptoms fit in each of these different domain categories, and they come up with different anchors for that. And then we have to all agree, okay, is moving from a 2 to a 3, is that really clinically meaningful, or is that just going to be some statistical aberration? So that'd be something that we're going to charge ourselves with. And then to establish this inter-rater reliability. And they actually created these vignettes, and they passed them out to different clinicians and different investigators in the trial and said, okay, if Johnny came in and Dad was saying that this, and this was better, how would that be scored? And it turns out if this is done correctly, there is quite good inter-rater reliability. And again, there's a lot on the slide, but this is what they basically came up with. So they put in these different domains of behavior, motor, expressive communication, sleep, put a severity scale here along 7. So behavior, moderately interferes, or you look into simple things like motor, uses hands to eat. So I'm imagining, right, a chart like this for our LGS patients that we could actually use moving forward. So I guess that's to start the discussion. This is my final slide. So I do believe this is feasible for our patient population. I think we obviously have a very engaged parent, patient, caregiver community. We have many, I put experts in air quotes here, expert clinicians that I think would be invested in this project. And so I think we could develop a CGI for LGS and encourage its use in clinical trials as secondary exploratory endpoints for these trials to hopefully see improvement beyond just seizure frequency. And that's all I got. No Folsom Prison Blues.
Cool. How'd it go?
Yeah. Great discussion. When you start to talk about seizure reduction, it's easy to happen early on as drug developers. But when you start to think about behavioral outcomes, they're happening much later, and our studies are designed often as 1, 2, or 3 month studies. Maybe disaggregate a little bit, maybe change those outcomes that you're talking about that are meaningful to a little bit longer.
Well, I mean, I think at least in some of the fenfluramine trials, it was a short period of time. So I think that as long as the proposed medication is not set up to make things worse, again, this is just my opinion, I actually think there is enough time in 14 weeks. If there's going to be some, I feel like you do longer than maybe things would separate, but is that really going to be clinically meaningful change? Again, I'm just throwing it out there for discussion, but we definitely do not want to send a message, I disagree with you, that we need to extend the duration of clinical trials and placebo exposure to try and get at this. I think that's where we need to get creative and try to come up with a compromise there.
Or I won't scream. Do you ever think about a design where the patient determines the duration of the study? Like, I know that Dennis and other people have brought that up, but it drives me crazy that everybody has to do the exact same duration when you're having hundreds of seizures a day. And I'm like, why?
That's a whole other discussion. Renee brought up already. So the time event design, I think, would be a great design for seizures and limiting, but then that's going to raise a bigger problem with, what's that?
Even this, if your behavior is atrocious, like, if they've called the police 3 times last week, I mean, come on.
So for that chart that you showed for
Yeah.
parents, is there something out there that you can share with physicians to give to the parents when they're first diagnosed?
Well, I think what, again, this is just to start the discussion. I think this would be a project that we would have to sit down as a group of clinicians and populate that chart with caregiver input in terms of understanding what's the most important and what's going to actually make someone go from a 3-mile improvement to a 4, so that we all agree upon it. So then when it's implemented into a clinical trial, the output is applicable to what we're doing in the clinics. I guess is so I don't have anything, but that's my charge to all of us to create it.
Last question here.
Oh, well, let's see. Can't get this.
I knew this kid. Yeah.
Just a comment, though, I think back to Sandy and the PCORI study, we can hopefully have some preliminary focus group data that will feed into what you're doing or wanting to do. That would be very helpful. So.
I think we have one online question too. Three. What are the reasons for excluding the over 35? What are the reasons for excluding the over 35 LGS population in this study?
I don't remember the answer to that. Actually, I apologize.
Great. And then where was this trial done? The one that you talked about? Which one was it? Which trial?
So this is the fenfluramine and
Oh, right. So it was done at multiple sites. Okay.
multiple sites, international.
Great.